First of all, I would like to thank you for inviting me to be with you today. Again, for those of you who don't know me, I'm Dr. Islam Elhelf. I am an associate professor of interventional radiology at Augusta University. I am also the program director of the IRDR residency. And today I will be lecturing about the fundamentals of interventional oncology. So as I agreed with the group, we will start with the percutaneous thermal ablation. Hopefully this will be a good lecture for you guys. Mariam has emphasized for me that we need to make it simple and very understandable for the medical students, which we will do. I promise you, if you give me just 40 minutes of your time with concentration, you will come out of this lecture with a very good fund of knowledge comparable to residents or even fellows. So let's start with the objectives just to get an idea what we are going through in this lecture. So if you pay attention to these points, this is what I'm trying to deliver in today's lecture. So we will understand the added value of percutaneous ablation in interventional oncology. We will understand the difference between the various ablation modalities and when to use them. And we will get all of them in one sitting. So we'll be talking about radiofrequency ablation, microwave ablation, cryoablation, and even HIFU. We will have some clinical examples and some animations so that you can understand what we are doing exactly. And then I will touch on the research trends and what's being done now so that we can look together about how the future looks like. So let's start with this. So for many decades, open surgery was the only way where you can achieve local control of body tumors. So basically, the idea was very simple. If someone has a tumor, we need to cut him open and get the tumor out. And this was mainly what's available. At that time, there was also the two other pillars of interventional oncology or of oncology treatment in general, which are basically chemotherapy and radiation therapy. They were mainly reserved when the patient has some spread of disease so that we can give some systemic therapy, which was basically chemotherapy. And this was the way we used to treat all of these tumors until we started to have the minimal invasive procedures that started to be now one of the main modalities that we use for treatment of tumors. So the difference between us and what the surgeons are doing is that we can introduce all our minimal invasive procedures through very small skin incisions. Most of the time, it is just smaller than any pin that you use. And then with this minimal invasive nature, there comes some very important benefits. So first of all, we do not need to cut the patient open like this. So we definitely decrease the morbidity and mortality for the patients. Most of the time, our procedures are done with moderate sedation or even sometimes with general anesthesia. We keep the patient only for some like 4 hours for recovery. Most of the time, they can go home same day, or like rarely, if there is any issue, they can go the next day. So they do not spend the week in the hospital. And of course, this results in less treatment cost compared to the other modalities. That's why when the minimal invasive procedures started to be widely adopted, they really become very well needed in the modern oncology practice. So as I mentioned before, today we'll talk about the minimal invasive thermal ablation techniques. Basically, we'll cover radiofrequency ablation, microwave ablation, cryoablation, and HIFU. Again, the beauty of all these modalities is, as I mentioned before, you can deliver all these energies with a very small probe that can go in through the skin into the tumor. Good thing that we are also radiologists, so we can monitor what we are doing either using ultrasound or CT or even MRI now in places where they have MRI compatible devices. So let's start talking about these modalities. But before I go into this, I want you guys to remember this slide. I believe this is one of the most important slides that you need to know if you are interested in oncology in general. And if you understand this slide, you will be able to understand any modality that's used. to treat tumors. So basically, how can you destroy a human cell? And you will notice here that I didn't say malignant cell or blind cell, basically all human cells. There are 4 ways that you can do this. So first way, which we are concerned about today, is to expose the cell to extreme heat, extreme temperatures, whether you are doing this with hyperthermia or hypothermia. So hyperthermia is where you take the temperature up to 60 to 100 degrees Celsius, and hypothermia when you go down to -20 or even -40 degrees Celsius. So when we did research, we found that when you put the cell in this very extreme temperature, you can damage any human cell. There is no difference between malignant or benign. There is no difference between healthy or non-healthy. You can also do another way, which is to intervene with the integrity of the cell membrane. So I know you are all medical students. You have studied in the histology and pathology the importance of the cell membrane. Basically, this is the main barrier. This is the mechanism by which any cell can control the passage of anything in and out. So if you can make these leaky, if you can make some holes and pores in the cell membranes, then the cells started to lose the ability to control the environment. And this what causes the cells to start to lose control and die. You can also put the cell in a toxic environment, which is basically what chemotherapy is doing. Or you can use radiation, which basically destroys the intracellular organelles, mainly it destroys the DNA. So these are the 4 types of interventions that you can do to kill any human cell. Now, the beauty of the thing that we are using is there is no really, not a single cell that is resistant to cerebral ablation. There are some types of tumors that are chemo-resistant. There are some types of tumors that are radio-resistant. They do not respond very well to chemo or radiation therapy, but there is nothing much about resistance to temperature. In other words, if you can get to your target of these extreme temperatures, you'll definitely kill the cell. Another big advantage is we do not have really limitations on how much we can repeat this. So if we get a recurrence or whatever, you can again do it once, twice, or 3 times. This is as opposed to radiation therapy, for example, where you have a radiation threshold. So you cannot accumulate more above a certain threshold, otherwise you can destroy the other, the surrounding organs. So this is the slide really I would like you to remember because, as I mentioned, anything in interventional oncology you can easily put under these 4 mechanisms. So let's talk about radiofrequency ablation. And I know this is a busy slide, I apologize, but it's really not as busy as you think. So I would try to simplify again. I know this is for medical students, but basically the information that you will hear in this lecture will be very important if you decide to go for shadowing or work in an environment where they are heavy in IO. This will really give you a good fund of knowledge so that you can even go into deep discussions. So radiofrequency ablation is basically what we are doing is we are creating a rapidly alternating electric current that passes between a needle inserted in the tissue, in this case would be the tumor, and then another thing. And the other thing is basically what we use, either another electrode or a grounding pad, which is more common in daily practice now. So basically, if you think about it, you are putting a needle in the tumor and you are turning the human body into a circuit. So there is an electric current that's going through the human body. And this is what I will show you in the next slide. So the way it works is basically when you have these alternating electric currents, you started to have lots of agitation of the ions around the needle. And this agitation results in friction, and this results in very rapid heating of the tissue. And this is exactly what we want. We wanted to get the temperature high very quickly so that we can heat or burn the tumor. Now, if you go in and you shadow in any IO or listen to any lectures, you'll find that if the tumor is 1 centimeter, people usually try to ablate more. Why we are doing this? Because basically we believe that what we see in imaging is just the top of the iceberg. You always have to include what we call a safety margin or an ablation zone. It's an extra ablation that you need to do beyond what you see so that you make sure that you are not missing any minimal cancer cells that are hiding. in the tissue. And this is, by the way, this is not only unique for us. Surgeons do this as well. So if you go and watch any of the surgeries, they always take more because they want to make sure they take everything out. In most of the applications, we try to go for a 0.5 to 1 centimeter. This gives us a good ablation margin so that we minimize the rate of recurrence. Now, the heat sink effect is something I really want you to know, guys. And I'm trying not to be super technical here, but it will make a big difference if you understand this. So as I mentioned before, the killing depends on taking the temperature very high and keeping it for some time so that you can destroy the tissue. Now, the problem, if you have anything that causes cooling of the tissue or takes the temperature down, this is actually working against you. And this is what happens if you have a blood vessel or a rapid blood flow next to the ablation zone. What happens is the flowing blood actually causes what we call internal cooling. It does not allow the temperature to go high enough to reach the threshold that we talked about. And this is what we call a heat sink effect. So you will be surprised now, like I'm sure like you as a medical student, when you see someone ablating close to a blood vessel, you are worried about the blood vessel. But actually the interventional radiologist is more worried about the cooling that will happen because of this blood vessel. And we use different techniques that we can try to minimize this. But I want you guys to remember the term. It's very important. You will hear it a lot if you go and work in an IO place. And it depends on two things. Again, it is the rate of heat deposition and the rate of cooling. This means that radiofrequency ablation is considered on the low side of heating, so it takes time for the heat to build up. Now, if you have a big sized blood vessel and this blood vessel is having lots of flow, it will definitely cause the cooling. And that's why most of the time, if we get recurrence in these tumors, it's always almost close to a blood vessel because of this cooling effect. Now, Mariam has asked me to try to put this in the context of the oncology paradigm, like when do we use these two things? So basically, most of the percutaneous ablations are designed for small lesions. Now, the definition of small lesions is very variable, but most of the interventional radiologists will agree that we are talking about either a single lesion less than 3 centimeters, or if we are dealing with metastatic lesions, we can do up to 3 lesions, each is measuring less than 3 centimeters. So why we are limited to this? Because the way it works is you create heat around the needle, and then this heat started to dissipate in the tissues. So there is a limit for how far the heating can go. And most of the research has shown that it is 3 centimeters. So if you have 4 centimeters, then probably you have 1 centimeter that may not be covered. So does this mean that we cannot really do anything more than 3 centimeters? The answer is no. You can actually combine sometimes 2 probes or 3 probes so that you can achieve a bigger ablation zone. Or you can combine radiofrequency ablation with other transarterial modalities like TACE or Y90 or whatever. Of course, the rates of recurrence will be higher, but this is doable. I don't want to go deep into the transarterial therapies. We can keep it for a later talk, but just wanted you to be oriented about when do we use these ablation modalities. Complications, yes, definitely there are complications. This is a procedure like any surgical procedure. There are risk of bleeding, the risk of abdominal infection, especially if the patient has some biliary intervention before. When patients have these interventions like Whipple surgery or sphincterotomy, the bile is sometimes colonized. So remember, when you kill the tissue, we do not remove it out. This is a big difference between us and surgery. We just kill it and leave it in place. And over time, your body will deal with it and will turn it into a scar tissue. But if there is a good medium for infection and you have a dead tissue, then you are in a very good chance to develop an abscess. Also, another thing is if we are dealing with central lesions, like for the example in the liver, there are some concerns that if the heat extends to the other structures like biliary ducts, it can cause some stricture. I want you to remember this, guys, because I will talk to you about something in a couple of slides that mitigate these problems, okay? So let's take a look and just see what we are doing. So basically, this is the setup. You have the patient. We assume there is a liver tumor. You put your needle in the tumor here, and then you put the grounding pad. And as you can imagine here, you are basically turning the human body into a circuit. There is electric current now that's going through the body, and the agitation is happening around the needle here. This is how it looks like. You put the needle into the lesion, and then you start turning on the generator. You burn the tumor, and you leave the tumor in place. This is a big thing that always medical students are wondering, like, you are not getting the tumor out. The answer is no, we are not leaving, we are not getting it out. We are leaving it in place because we know if it is dead, it is really turning into a scar tissue. It is not causing any problem. Mariam asked me to put some cases, so I'm just putting a case for you. This is a tumor here. You can see it. I'm not sure if you can see it on your screen, but this is the outline of the tumor. And this is our needle in the tumor. Then when we turn on the generator, you started to have the heating. And like you are doing any heating before, like imagine you are cooking liver in house, there will be some bubbles. You started to see bubbles developing around the needle. Not sure how much you have about ultrasound, but in ultrasound, air is usually echogenic, which means that it's white. It will be white in color. And this is what you see here. Now you see this white cloud, we call the echogenic cloud. This is basically telling us that the burning is happening and covering the tumor now. So this is how it looks like during the ablation. If you are shadowing and you see this, I know it sometimes looks scary. If this is the first time, you're wondering what's going on. This is actually how it looks like. When you do CT, basically what we use in imaging is what we call the enhancing. I don't want to go too much into technical things, but this is basically a CT here with contrast because we see the artery very bright, so we are giving contrast. And you see the tumor there is actually the same color maybe as the other liver tissue, or maybe a little bit more. This means this is a viable tissue and actively taking the contrast. After ablation, it turns into a dark spot, which tells us that we did a great job here. We killed the tumor. You will see some halo of uptake. This is basically the tissue, what we call the hyperemia. This is the area that was touched by the heating but was not killed. It's something that's very expected. And that's why I always mention that we get a bigger area than what we see on imaging, just to make sure we have a good margin. So this is for radiofrequency ablation. Now, if we switch gears to microwave ablation, which is also some sort of thermal ablation, again, busy slide, but we will make it very easy for you guys. So microwave is a little bit different than radiofrequency. So radiofrequency, as we mentioned, there is an electric current that's going through your body. Microwave ablation is not like this. Basically, this is like the microwave you have in home. It's exactly the same technology. The only difference is they made it designed it to go through a needle. So when you put it in, it starts to agitate the water molecules. And this actually creates the frictional heat and causes the heating. Okay. Of course, we don't need grounding pads now because we are not trying to close a circuit. This is just, as I mentioned, that some activity around the needle. So why microwave ablation now became very popular? It even surpassed the radiofrequency ablation. This is because of two things, and I want you guys to remember this. Again, if you go and shadow in IO places, these things you will hear a lot. So it produces a larger ablation zone. It is faster. So it is larger and faster, which is basically very, very beneficial in IO. Larger ablation zone means that we can destroy bigger tumors. Faster will bring us to the heat sink effect. You remember I told you the heat sink effect is basically a balance between two things. It is the rate of heat deposition versus the rate of cooling. Now, if you can achieve the heat faster and faster, you do not allow the blood to cool the tissue. So that's why you can get bigger ablation. Okay. That's why, as I mentioned now, most of the time, microwave ablation is becoming very popular in many places. Now, this comes with an expense, which means that your ablation zone is larger. So you need to be really very careful because, and I will show you this in the next slide, the ablation zone for microwave ablation is very characteristic. It has what we call a teardrop appearance. It likes to grow along the needle. So you have to be very careful. If you are ablating, this ablation zone may extend back along the needle and burn whatever is there, like the chest wall or whatever. That's why we'll talk to you about what we call dissection techniques. I'm sure if some of you have done shadowing, you have seen this, but for those of you who did not see it, just wait for one slide, I will show it to you. So microwave ablation is again used for a single lesion typically, and you will see here that I added 2.5. So again, because we have a larger ablation zone, now we can do up to 5 centimeters. Metastatic lesions, we still have the same concept. We prefer to have 3 centimeters, less than 3 lesions. This is where we get most of our benefit. But again, larger lesions, we can treat either by using multiple probes or by combining it with transarterial modalities like we talked before. Same complications are as RFA, exactly. It is the same thermal ablation thing, so we share the same complications. So this is the slide that I wanted to show you guys, and I wanted to start from this one. So if you have your tumor here and your needle, the challenge with microwave ablation is that it likes to grow like this. It likes to cause what we call the teardrop appearance. Now, with the advances of modalities and techniques, they are starting to make it more spherical, but the classic teaching is it's like this. So if you are doing ablation, you really need to make sure that this is not growing back to burn anything that you don't want to burn here. And this is where the dissection techniques come. So what we do is basically we go in and try to inject the fluid or gas so that we create an isolating plane, try to push the critical structures away from the ablation zone so that we cannot or we do not destroy the tissue. This is an example of a case. Again, this is a CT. This time the patient is prone. Prone means that they are on their belly. So this is the back, you have the spine, and this is the abdomen here, and this is the kidney, and this is the other kidney. And it's obvious that we have a lesion here. So we decided to go in with a needle and ablate it. But because we wanted to make sure we will not burn the abdominal wall, we introduced this. You see these black things? This is actually not normal. This is carbon dioxide or CO2 that we went in, we injected to create this isolating plane. Basically, we are trying to push the kidney away so that we can have a space that even if the ablation extends back, we are still safe. We are still in just the retroperitoneal fan. People have done this using CO2. People have done it using some saline or D5W. You can do it. We do it many of the times with the colon, try to get the colon away. This is just something for boards exams. It's a very common question that with radiofrequency ablation, never use saline. Because if you remember, radiofrequency ablation works by ionic agitation. So saline is a sodium chloride. This is a very highly ionic medium. So if you put it, you actually will increase the ablation zone. So you have to be very careful. You can use saline with microwave or cryoablation, but never ever use it with radiofrequency ablation. Now we switch gears to cryoablation. Again, appears busy, but we make it very easy for you guys. So this is basically the opposite extreme. So radiofrequency and microwave, we were heating. This time we are freezing. So we are bringing the temperature to a very low temperature, like -20 or -40. You will be surprised that when we are doing cryoablation, we are not only freezing, we are freezing and thawing. This means that we allow the ice ball to form, and then we thaw it. And then we ice form again, and we thaw it. Why we are doing this? I'll just explain in the next slide. But the good thing about this modality, and it's really, really a big blessing, guys, is that you can easily monitor the growing ice ball. So unfortunately, with microwave and radiofrequency ablation, especially when you are using CT, you cannot really see the burn. You can detect or predict how big it will be based on some charts that come with the device, telling you if you use this probe, you will get 2 centimeters. If you use this probe, you will get 3 centimeters, stuff like that. But you really cannot see it. Even when you do ultrasound and you see the echogenic cloud that we talked about, it is known that it exaggerates a little bit what's going on. But with cryoablation, you can see the ice ball very well. So you can be 100% sure that you are covering your tumor. And I will show you this in the next slide. The treatment actually is remarkably less painful. Think about it like when you get any trauma to your hand or your foot, what's the first thing you do is you get some ice and you put it on it because the ice numbs the nerves. And this is the beauty of this, that now we can even do these ablations using just moderate sedation. With microwave or radiofrequency ablation, we do general anesthesia because it's painful. But with cryoablation, we can actually, in select cases, do it with just moderate sedation. This is the big advantage, guys, that I want you to remember this, what I teach my medical students. Ice is nice. That's how we call it. We notice that this ice ball is very nice and gentle to the epithelial surfaces. So if we are dealing with a renal tumor, for example, and this renal tumor is very close to the pelvic calyceal system or the ureter, when you get this ice ball, even if it extends into the pelvic calyceal system, it usually is not a big deal. Maybe some minimal hematuria, but it is not a big deal. If this happens with radiofrequency or microwave ablation, usually will end up into a big problem, either a stricture or a perforation. So this is a big advantage, and that's why cryoablation really is very widely used for renal tumors. Now, the disadvantage is we do not have the cauterization effect of radiofrequency of the microwave. So it is usually associated with a higher incidence of bleeding. Although the new systems now have included some ablation, what we call tract ablation. So this provides some kind of cauterization that minimizes this. Cryoshock is something that was there before. I honestly didn't see it in my current practice, but this is something that I just wanted to throw it here so that you have heard about it. It was some kind of a cytokine-mediated reaction that was noted with some cryoablation. Also, we have to be careful with liver ablation using cryoablation because sometimes, as I mentioned, maybe some hemorrhage and maybe just because the ice causes cracks and the parenchyma cracks, so it can cause some bleeding. This said, we still can do some cryoablation in the liver, but it is not as popular as in like other areas like the kidneys, for example. I usually like to go a little bit into physics so I understand what you are doing. Cryoablation uses what we call the Joule-Thomson effect. This is a very basic physical phenomena in which if you have a highly compressed gas that you allow it to suddenly expand into a bigger chamber, it results in significant drop in temperature. And this is actually how your fridge is working at home. So you have the Freon gas compressed in these tubes, and then when it allows to expand, that's how your temperature is going down in the fridge. It's the exact same thing here. Basically, the argon gas in this case is compressed. You allow it to go into a bigger chamber. It takes the temperature up. The nice thing is the ice balls are really very well controlled, as you can see. So you can choose the size that you want. And this is what I was talking to you about, guys. Like this is a phantom, of course, but you can see this dark thing. This is the ice ball. And you see how beautiful you can see it. This 100% makes you sure that you are covering your target. Again, this is a case that I wanted to show you guys. Again, this is the kidney. This is the tumor. And you can see easily that the ice is forming around. So now you can easily tell that you have covered your tumor. I'm not sure if you can see it on your slide, on your screen, but this is basically the original tumor. And you will see an extra darkness here. This is basically what we call the margin. So we are doing more ablation so that we can make sure that we are taking care of the whole thing. Now, why we do freezing and thawing? Basically, during the freezing, you are causing cracks in the cell membranes. Remember, the second mechanism of ablation was to make leaky cell membranes, right? So this is what happens when you freeze. You create ice. The ice causes cracks in the cell membrane. Now, when you start thawing, because the cell has lost the ability to control the flow or the water movement, lots of water will go in. These cells will start to swell and they rupture. And that's why we kill the tumor by apoptosis. That's why it's very important to just realize that it's not only about freezing, but we do freezing and thawing as well. Okay, So far we have talked about microwave and radiofrequency ablation, and we said that the beauty of this is that we can put this through just a needle into the tumor, right? It's a big advantage. But what if I tell you that we also have now a modality that you do not even need the needle? You can just shoot from outside without even needing the needle. And this is the beauty of high intensity focused ultrasound, or HIFU. Just for you who do not know my background, I spent about 5 years doing research only on HIFU. So I'm fascinated by this technology, and that's why I wanted you to know about it. So let's talk about it. So HIFU, or high intensity focused ultrasound, is basically, as the name implies, it is a non-invasive method. It's not minimally invasive, it's non-invasive for treatment of body tumors. So the idea is very similar to this experiment that we all tried when we were young. Basically, when you used to use the lens to focus the sun rays to burn something, we do exactly the same. But instead of using the sun rays, we use ultrasound. And instead of using the glass lens, we use focusing techniques that I will talk to you about. So basically, these are high intensity beams that are highly focused. So I like to include this study because this slide, because some medical students came to me and they thought that the machine that's doing this is the same one that you have in diagnostic radiology. This is not true. These are dedicated machines. Yes, we use ultrasound, but in order to reach these high intensities, which reach thousands greater than we have in diagnostic radiology, we need to have very big generators. So I just wanted you to be aware that these are dedicated machines. As you see here, this is actually the generator. As you see, it's very big. Usually in the diagnostic machine, it is just below the screen, but this is what we use. So first of all, you need to generate very high intensity beams, and then the focusing, which was actually very, very important, how we can get these beams into just one side. There are what we call acoustic lenses, which are basically very similar to the sunglass lens that we use. These are some lenses formed of some materials that have some acoustic properties, so that when you focus the beams, they can put the beams into one dot. But what's more interesting and more fascinating now is what we call electronic focus, or STEAM. So again, I don't want it to be super technical, but it's a good chance to give you some terminology. I think this is what I was instructed to give you an idea about the terminology. Okay, guys. So most of the ultrasound that we use nowadays is called phased arrays. This means that the ultrasound probe that you hold in your hand is not formed of only one element. There are actually hundreds of elements. So electronic focusing basically means that if you change the electric current going into every single element, you can play with these things to allow the beams to converge into different points. So it can be like this in the center. If you change the electric current, you can get it up, get it far in, or even create multiple foci. And this is actually very, very nice because you can ablate multiple areas at the same time. How does it work? You will be surprised that it is also a thermal model. So again, physics is very important in radiology, guys. And if you decide to go to radiology, you will study physics separately. So the ultrasound beam is basically a beam or a wave of compression and rarefaction. It is just alternating. When you get all these high intensity waves into one particular side, you really have lots of acoustic pressure. This means that there are lots of compression and rarefaction happening in a very small amount. Very small space, and this what creates the ablation zone for HIFU, which is very characteristic. It's like they call it the rice seed. So this is actually, will be surprised that this is very small. We are talking about 3 millimeters. If you want to see it in real life, this is how it looks like. Again, this is one of my experiments when I was experimenting. So this is actually when you get, this is a single focus. So how can we treat a tumor if it was like this? We basically try to stack these ablation zones side by side so that we can cause the ablation to cover the tumor. Acoustic cavitation is very important, and I will tell you why in a second. But basically, any mammalian tissue has some microbubbles. We have microbubbles in our body, believe it or not. But these bubbles are in a very stable, stationary position. Okay, that's why you don't feel it. They don't do anything. When you put these bubbles under the HIFU effect, they started to oscillate. At the beginning, this oscillation is very steady and stable. This is what we call the stable cavitation. It causes some heating of the tissue, but not really harmful. Now, if you exceed a specific threshold, and this threshold is different for the different tissues, liver is different from the kidney, from bone, whatever, these bubbles cannot tolerate any more pressure, so they will rupture. When they rupture, they cause lots of damage. This is what we call inertial cavitation. This rupture powers, guys, is very strong. Some people argue that it can actually break a piece of diamond. Okay, so when you have these explosions in the tumor, this is how you kill the tumor. Okay, so thermal ablation, plastic cavitation, and third thing is mechanical effect. I will not go into the deep end of this, but it's just like you are having a hammer and you are knocking on the tissues. So there are some mechanical effects associated with HIFU as well. So let me go with you through very quick clinical applications of HIFU, just so you get oriented about when we use this technology. Okay. So first, before going into it, I just wanted to put some images here to show you an important concept, because we said HIFU is focused ultrasound, right? Which is correct. But remember that we do not have a needle in the lesion. So how would we know that the ablation is happening? And how would we know the extent of ablation? Are we under or over ablating? We do not know because we do not have a needle inside. So we will use imaging. So you can actually use ultrasound to see what you are doing. This is what's called ultrasound guided HIFU. Or you can use MRI to see what you are doing. This is called MRI guided HIFU. Okay. So the way these machines work is basically, this is where the magic happens. So the transducer actually has two components. You have the therapeutic component here, and you have the imaging component here. So that when you are doing the treatment, you can treat with this and see what you are doing with this. And what you will see, if this is an ultrasound guided machine, you will see the echogenic cloud that we talked about before. This is how you know you are doing the ablation. Okay. So HIFU is being used now for treatment of uterine fibroids, liver cancer, and there are lots of applications. Actually, of course, as you know, in the United States, we have the FDA regulations. So sometimes we do not do everything, but there are more applications in Europe. People are using it for pancreatic cancer, for breast cancer, for renal cancer, lots of applications. And I wanted you to also know about histotripsy. I actually added a slide for you just yesterday to make sure we have covered this. This is becoming very popular now and very fancy as well. And I will cover with you quickly what we call targeted drug delivery, because as I mentioned, I just wanted you to know the future, where we are going. Let's keep this interesting. So I will show you now a case of treatment of a liver tumor. Just want to make sure you understand. So we put the patient on the table and we actually do the following. So we start imaging using our imaging transducer here. We are basically scanning the liver to see where is our target. Once we see it, we will turn on the treatment generator or the transducer. So this is the green is the HIFU and the blue is the ultrasound, diagnostic ultrasound. This is how the treatment goes. We keep doing this, what we call sonications, like shots, so that we can cover the tumor over time. Everything is controlled from here, as you can imagine. This is a case that just show you, this is of course one of the extreme cases. This is really a big tumor and in a very challenging location. Usually the tumors that are very close to the heart or the dome are very challenging, but as you can see here, again, before the ablation, you see all this enhancing tissue. After the ablation is becoming so black. So this is how it works. So let's see how uterine fibroids, for example, we treated. This is very common to be done with MRI-guided HIFU. This definitely can be done with ultrasound-guided HIFU as well, but this is more common in the United States. So we basically put the patient in the scanner. We do the MRI. we see the fibroids, and now we started to do our sonications. So the probe will be moving to shoot at the tumor until we cover the whole tumor. And again, we keep repeating this. The good thing is the ultrasound really goes through the tissues, does not cause any harm before or after the focus, ideally. So this is basically the beauty of this kind of treatment. Again, Mariam has asked me to include some cases. So this is a very nice case. This is a lady who have an intramural fibroid with some submucosal component here. When we inject contrast, you see everything, it becomes bright. This means that this fibroid is very viable and it is very thirsty. It drinks lots of contrast. Now, after we treat it with contrast, you see the black area, which means that this is already treated, what we call the M.B.B.Ch or the non-perfused volume. And when you follow these fibroids over time, this is what we talked about. It turns into a scar tissue, so it starts to get smaller until it disappears. So this is again a very minimal invasive treatment modality, and the good thing again, it's very convenient. The patient can go home the same day, no incisions, no major stay at hospital. Histotripsy is something, as I mentioned, I just added this slide yesterday just to make sure you have every updated information about what's going on. This is basically an ablation modality that's using the acoustic cavitation. As we mentioned before, the bubbles, when they rupture and they kill the tissue, this is basically what is happening. This is non-thermal, and it's very important, guys, to understand the difference. This is non-thermal. There is no heating here. It just destroys the tissue from the rupture of the bubbles. And this brings lots of very nice criteria. So first of all, we do not have heat sink effect, right? Because we are not using heating. So we do not care actually about the blood vessels. In fact, it has an additional advantage, big advantage, is that it is very nice and gentle to the collagen-rich structures. This means blood vessels or bile ducts. And this takes us into very important domain, which basically means that you can treat very central lesions in the liver and you are not concerned about causing any damage to the bile ducts. You can treat in the kidneys without too much damage to the urethelium. So that's the beauty of this technique. And I wanted also to know about the abascal effect, because you will hear about it if you work in an IO place. This is basically what was noticed is sometimes when you treat one tumor, let's say the patient has one tumor in the liver but has metastasis in the lung and the spine, for example. So it was noted that when you treat that lesion in the liver, some other lesions started to get smaller. And this means that there is some activation of the immune system from the mechanical debris. This is a big topic. I don't want to go deep into it, but I just wanted you to hear this term, abascal effect. Some people are doing lots of research now about using the immune modulating medications even to enhance this effect. But histotripsy is known to be one of the most influencing techniques that are actually working in this domain. This is actually how it works. Again, you put the patient on the table and then you do your imaging and you start to focus your beam into the tumor. So what will happen is the cavitation will start to happen exactly as we talked before. You keep doing this and these bubbles will start now to rupture. And as they rupture, they basically liquefy the tissue. So if you see these in samples, the tumor is like a jelly after it's treated. The nice thing about it is there is a very sharp demarcation between the dead tissue and the untreated tissue. This is very important. Gives you a very clear margin. And also, as you see here, the blood vessel is intact. This means that if this tumor is encasing the IVC, you can treat it with histotripsy. You need to think a lot if you are using a microwave or radiofrequency ablation. This is the future. So targeted drug delivery. I'm sure you have heard about chemotherapy, and the patients, when they get chemotherapy, get side effects like falling of hair and lots of other things. This is basically because when you inject the chemotherapy in the veins, it goes everywhere. In addition to your tumor, it goes everywhere, liver, kidneys, everywhere. And this is where the side effects come. So the idea was, what if we can enclose the chemotherapy into some vehicles that will keep it protected. And then when they reach to the tumor site, we can release this chemotherapy so that it's released only in the site of treatment. It was a very thoughtful idea, but was it possible? The answer is now, yes. So we have what's called the temperature-sensitive liposomes. These are basically vehicles. You put the chemotherapy inside, and then we inject the chemotherapy. And what happens is we started to heat the liver tumor, for example. And then when the liposomes will reach to the liver in this area, because it is heated, they started to be leaky and they will release the chemotherapy. While the other chemotherapy circulating everywhere else is not releasing anything. So we are minimizing the side effect. Let me show you this animation just to give you an orientation. So this is basically what happens. So we started to do some local heating of the tumor. We are not burning the tumor. We are just raising the temperature a little bit. And then we injected the temperature-sensitive liposomes. And then this will go in. And because we are heating this area, you will see that when these liposomes reach to this area, as you will see, it will start to release the chemotherapy in these areas. This is what makes it very concentrated in the tumor, and it makes the side effects less obvious in other areas that are not heated. So with this, I have reached to the end of this presentation. I hope that it gave you an idea about all the modalities that we are using. Before I conclude, I wanted to let you know about something. I'm sure some of you may know about it, but this is IR Pathway, basically an educational platform that I started to teach interventional radiology. Basically, it's available in Arabic and in English now. This is a platform where you can find lots of tutorials. We have some notes that follow the tutorials as well. We have some animations and illustrations so that you can simply understand the main concepts. We also provide mentorship. So we have helped lots of people from the Arab world and from the area to get some very nice scholarships in the United States. And I'm more than happy to help anyone who is interested. And we have even started some quizzes section so that you can test your knowledge. This is all available for free. So I encourage you guys to go ahead and join us in this platform, join it with your colleagues, and hopefully we can all learn together and keep learning, inshallah. Thanks so much for your time, and I'm very happy to get any questions you may have.
Thank you so much, Doctor, for such an insightful session. If anyone has any questions, please feel free to ask.